Good morning, ladies and gentlemen. I am Yashwant Tiwari. Am I audible? If I am audible, just write yes, why in your comment box. I think I am audible. Yes. I have started receiving responses. Yes, thank you very much. No problem, no problem. I just wanted the confirmation that I am audible. Friends, MedDwise Circle and Anamol Laboratories in collaboration has conducted this webinar for you all. And I'm thankful to you all, those who have joined, that in spite of being year-end closing month, you all have agreed to join this this training session because of the trainer today. Our trainer is very important and very senior person of the industry who carries experience more than 40 years. The name of the trainer or name of the speaker is Mr. Mahendra Dashora. Mr. Dashora carries the experience of over 40 years, having worked in in two companies. First, he worked in biodiagnostics for 3 years as a research scientist from 1981 to 84, and then he joined Accurex Biomedical as a managing director. There he worked for 20 years. Then thereafter he started his own company, Anamol Laboratories. He has been working as a managing director, having age of very young and energetic, hardly 70 years old. So though his age is 70, but we call him 70. His energy level is only 17-year-old boy's energy level. His qualifications are tremendous. He has done his post-graduation for the youngest people. He completed his post-graduation 20 years before your birth. He completed his post-graduation from MB University, Udaipur in 1979. Then thereafter he decided to go for second post-graduation degree, and he completed his MSc in biochemistry in 1981 from MS University, Maharaji Sayaji University, Baroda, which is one of the prestigious universities of India. And he has so many firsts on his credit, so many feathers in his cap. But if I have to list few of them, he is the first person, he is the first Indian who has indigenously manufactured enzyme-based lyophilized powder in 1981. He is the first person who indigenously manufactured the urine test strips in 1984. He is the first person who has indigenously manufactured liquid stable reagents in 1992. So without taking much of your time, I would like to invite Mr. Mahendra Dashora, because the time allotted to me was only 90 seconds, but I have consumed more than this. Thank you, Dashora sir. Those who feel that Dashora sir deserves a grand welcome may write WC in your comment box. Let us see. Yeah, great. Thank you, Namrata. Thank you, Jaldeep. Thank you, Priyankji. Thank you, Paridat. Thank you very much. No problem. Dashora ji, over to you. And welcome to you, sir.
Sir, good morning to everybody. And putting so many WCs put a pressure on me to perform. Okay, sir, it is a grand event from my point of view. Since last 40 years, I have been in the field of educating and empowering the technicians and salespeople in the line. Because that the time era when I had started in 1984, the education level was very low in the terms of performing the clinical chemistry test. That is where the challenge came in, and I said, no, all the laboratories people should be empowered in terms of reagent availability, not putting the pressure on multinational companies and big hospital to send their sample to. And at the same time, when they consume the clinical chemistry reagent manufactured in India, they should be empowered to even understand that. I remember when I started Accurex in 1984 and 86, when we launched the product, first 5 years went in training the salespeople only. We used to only hire BScs and MScs in the line, science graduate at least. So we were constantly giving them principles of the product, the technology behind it, the application, and the analyzer programming and all that. that made everybody empowered, and the whole movement started in the country where people became knowledgeable to implement, test, and program the analyzer without having troubleshooting. Although troubleshooting was always there because it's a technical subject, it's not a toothpaste, it's not a consumer commodity. Hence, I had to travel across the entire country along with the sales guys and used to visit customer lab with the difficult situation, the problems to solve them. And after every problem solution, we used to come down, sit in some place, even on the staircase outside the customer premises somewhere, and used to discuss it out that how did I attempted to resolve this particular problem. Because 99% of the customer complaints or technical difficulties are basically within the four walls of the customer laboratory. They have to keep on giving accounts of that, and we find out the root causes in that, and then we used to solve the problems out. Now, when Yashwant Tiwari ji came forward, say that we can share this knowledge and workshop kind of a thing with everybody in the country, I said most welcome, because my whole purpose of the life is to educate and empower people so that they have enough knowledge and competency to address difficult situation, the laboratory testings. Okay, sir. So when whole idea came in, the number of questions started pouring in. We had limited number of questions in the first, let's say 3 4 days back, up to 12 or 13 questions, out of which then I said we categorize the questions and we put common questions together. And that is where I decided that we will take up today three questions which are one related to, and these are all three as a burning problems. Let me remind you is that alkaline phosphatase has been a one of the chemistries which yellow color in the working solution has been a tremendous problem. See, I am constantly talking in English. That anybody wants it in Hindi, we can convert that in the Hindi also. Okay, wherever you find difficulty, please explain this part in Hindi. Well, I'll do that. मैं हिंदी में बहुत अच्छा हूँ because I'm from Rajasthan. So you can feel free that I can communicate in Hindi with anybody who wants to explain the things in the little more simpler way. Alkaline phosphatase is one product
Sorry
which you
sir,
take.
disturb कर रहा हूँ just for a second. Those who want in Hindi may write in comment box H.
Okay, sir. Fine. So I'll wherever absolutely critical one, which I'll take it up in Hindi also. बहुत डिफिकल्ट जो चीजें होंगी मैं उनको हिंदी में भी समझाने की कोशिश करूंगा, बिकॉज अगर वो पॉइंट हमने ठीक से समझ लिया, दैट मीन्स वी हैव अंडरस्टूड द मास्टर की टू सॉल्व द कस्टमर प्रॉब्लम. ओके, सो द अल्कलाइन फॉस्फेटेस इज वन, जिसमें येलो कलर डेवलपमेंट इन working reagent is the major issue. And years and years on, a lot of people are struggling to find the answer of this problem. How to get rid of this yellow color, because yellow color contributes to the blank, and hence the blank is high value of the patient, especially the children, where the unit normal value it says up to 800 units. So how do we estimate this? And most of the reagent goes wastage because the blank is very high. So this is one area where we'll address this. This is probably not a very technological issue. It's a more of a logics and reagent presentation. So we'll address one is this. Second one we will address is that a lot of people have come out with this saying that results authenticity with the terms of control sera, with the terms of clinical expectation, with the terms of clinicians expecting or accepting the results value is to be addressed in terms of factor. So we'll work upon the factor, how the factors really work, how it's get affected, and how the results are going to be made acceptable to the our internal customer or external customer, whatever we talk out to the patient. Okay, so that is the second topic which we'll take. And the third topic which we will take today is how to get correct and reproducible results in creatinine assay. Why creatinine assay? Because that is a 2-point kinetics, and many people make some fundamental mistakes in creatinine assay. So we will take that as the last one. My request to everybody is, अगर आपके पास में कोई questions हैं, note it down in a separate way or put it in the comment box, because if we take the question in the middle, the session will become longer. So we'll restrict the questions at the end of the question answer session. I'll give sufficient time for you. I'm available till evening, whatever you time you want, many number of questions, we'll take it up. No problem at all. Or you can put the question, we will take it in the next session also again. So dear friends, let's start with the alkaline phosphatase. Yellow color, major trouble making in the country, that most of the companies find it very difficult to address this yellow color issue in the clinical chemistry reagents. Okay. Are you able to see this slide? Okay. So IVD troubleshooting web seminar series only on Sundays. And that's by me, our company's address, website, most of the things are available
Yes,
and
sir,
not
we can
very.
see it.
Yes, sir. Let's go to alkaline phosphatase, reagent stability, reagent blank color. I thought this is a very, very burning problem most of the laboratories are facing. So let's understand what is this. First, we will see this. What is the principle of the chemistry? It's very simple thing. Paranitrophenyl phosphate, and alkaline phosphatase comes from the serum, breaks it down into paranitrophenol and phosphate. This paranitrophenol automatic breakdown is the major culprit, and that gives a yellow color. Okay. So paranitrophenyl phosphate is the substrate. Unsafe. This is highly unstable. I'll tell you why it is unstable. This is light sensitive. This is a heat sensitive. Okay. Breaks down into paranitrophenol, which is a yellow color compound. Okay. Same principle, keep it in the mind. Let's take this paranitrophenyl phosphate. This is available in 3 different salts. These are used in various clinical reagent preparation. One is the sodium salt, one is lithium salt, one is trace salt. Different companies use different salt to prepare the reagents. Okay. This is dissolved in diethanolamine buffer pH 9.8. Just to give a background, what it is presented as. Okay. Now, let's look at the enzyme alkaline phosphatase, which is a non-specific enzyme. It is not PNPP phosphatase or something like that. It is a non-specific enzyme towards the substrate. That means any phosphate bond which is to be made available for metabolism in the body, this phosphate bond is to be broken down and the phosphate is made free. So we use paranitrophenyl phosphate as a weak phosphate bond and substrate for enzyme to act upon under alkaline condition. Okay. This is what I said, weak phosphate bond. And this weak phosphate bond is prone to get automatically hydrolyzed by light as well as by heat. Okay, these are 2 major culprits in our clinical laboratory always. These 3 different salts have a different sensitivity towards the light and heat. Okay, so some of them can get broken down faster, some of them gets broken down little slower, depending upon which salt and which combination different companies are using. The sensitivity of the yellow color depends on the light and heat condition as well as the salt condition together, which is light and heat condition is variable at the laboratory level, and salts are formulated by the companies. This is 2 factors which are independent, but they contribute to different yellowing of the color of the reagent. In alkaline phosphatase, it is very clearly said that if the absorbance is beyond 0.7, that means 0.7 absorbance at 405 nanometer, use within that only by putting that as a 0 setting in the kinetic reaction. If it is more than 0.7, please discard this reagent. It is no more having enough amount of paranitrophenyl phosphate, which is broken down to paranitrophenol, is not available further to give entire linearity of alkaline phosphate, which is coming from the serum sample. Okay. Now, let's look how do we reduce this yellow or yellowing of the reagent. Okay, since we have understood why this yellowing happens, light heat, and the salt preparation. So let's attempt. Since it is a light sensitive material, so the best advice is to store the reagent in a dark container. As far as possible, dark brown or black color container. This is important when you are able to make reagent as a working solution, mixing R1 and R2 or dissolving the tablet. So ensure that you use the dark container. Number two, you store it as far as possible at the very low temperature possible. Bring and consume it as soon as possible before it turns yellow. Okay, these are the three major things which we can work upon, because substrate we cannot standardize and stabilize. It has to be weak. So only thing is to take care is dark container, low temperature, and fast consumption. Okay. Further more things. If it is a tablet and diluent based reagent, reconstitute tablet of the smallest possible volume, 5 ml or 10 ml, and reconstitute only when you require it. Don't keep it for a long period of time. If it is a liquid reagent R1 and R2, especially R2 which has paranitrophenyl phosphate, bring to room temperature only the volume which you require. Otherwise, keep the entire R2 reagent in the dark and low temperature area. Okay, this is how you can maximize the usage into productive. One more solution which I used to practice and I want to suggest to you is whether it is a working solution or whether it is a R2. If possible, divide into smaller volumes. Put it in microcentrifuge tube, dark color, and store in the deep freezer. This will arrest the auto hydrolysis of paranitrophenyl phosphate into paranitrophenol. These are the three things which have been helping a lot of people maximizing the entire reagent usage into reportable results instead of yellowing and throwing or putting or wastage. More important for everybody is whenever they have the reagent, every ml should go into reportable results instead of wastage. This is what my suggestions are for making the maximum usage of the alkaline phosphatase reagent and avoiding the wastage of reagent because of yellow color, which is exceeding 0.7 absorbance at 405 nanometer. Okay, I have been little fast. For somebody's पुटिंग इनटू हिंदी, मैं एक छोटी सी चीज मैं आपको समझाना चाहता हूं कि अल्कलाइन फॉस्फेटेज रिएजेंट चाहे वो वर्किंग सॉल्यूशन की फॉर्म में हो या लिक्विड R1 R2 की फॉर्म में हो, जिस जिस रिएजेंट के अंदर पैरानाइट्रोफिनाइल फॉस्फेट है वो रिएजेंट को आप डार्क कंटेनर में स्टोर करिए, लो टेम्परेचर पे स्टोर करिए, और अगर हो सके तो उसको रूम टेम्परेचर पे छोटे छोटे अमाउंट्स में लेके आइए, जो कि आप बड़े वॉल्यूम को डिवाइड करके डीप फ्रीजर में रख सकते हैं। उससे आपका येलो कलर अरेस्ट होके आपको हमेशा फ्रेश ब्लैंक देता रहेगा, ताकि आप ज्यादा से ज्यादा रिएजेंट कस्टमर या पेशेंट की रिपोर्टिंग के अंदर यूज कर सके, बजाय येलो होके फेंकने के बजाय। दिस इज व्हाट आई हैव कन्वर्टेड इनटू हिंदी। ओके सर, any questions you can keep it in your chat box, or then we take it into the next one. And next one is our presentation. Let's go to the slide number 2 straight away. I hope you are out of the yellow color of alkaline phosphatase now. Let's take the second problem. The second problem is the results reliability and calculating the factor and reproducing the factor regularly. I hope this switch is easy for you. We have had a talk about alkaline phosphatase yellow color. Now we are absolutely switching over to the next topic. So please wipe out that alkaline phosphatase memory and get into the factor and results. That is another major issue in most of the laboratories. Okay. In a clinical chemistry reaction, we are starting the factor. Okay. Clinical chemistry reaction, there are two types: endpoint and kinetics. Factor is used in both of them. What is the factor? Normally, factor is when you run a patient sample multiply the absorbance of a patient sample into this factor, and you get a concentration of the analyte. How this factor is calculated, let's understand that very clearly. This is a fundamental understanding on the basis of which our knowledge of problem solving will be addressed on. The factor is nothing but a concentration of standard and calibrator. When you run them as a test, you get an absorbance. So concentration divided by absorbance is the factor. Most of the time when you run this test, the factor goes into the instrument's memory by asking questions or automatically, and it gets stored in the memory. And every time when you run the sample, only it multiplied by that factor and gives you answer. Or sometime it is people who always establish fresh factor every time they run the test. Okay, it's a choice. This factor, how many things it depends on? Depends on reagent and sample volume. More the sample you take, more is the absorbance, hence less is the factor. The reason simple, concentration of standard divided by the absorbance of that, or concentration of calibrator divided by its absorbance when you run a test. So the factor is inversely proportional to the sample volume used. So more sample you use, more the absorbance comes in, hence the less is the factor. So factor depends on reagent and sample ratio or volume, as also factor depends on the what wavelength are you using it. Okay. Now I'll just give you a little example is that when you do any NADH based chemistry, absorbance is measured at 340 nanometer. Some analyzer in the olden times by Roche had even 365 nanometer, and the factors were established on the basis of 365 nanometers. Some of the analyzers where clinical chemistry tests are performed at 505 nanometers. Some of them are having a filter of 510 nanometer. Some of them you use the filter 546 nanometer. Absorbance change. And this absorbance is what is responsible for different factor at different time and different setups. Okay, so you have to keep in mind reagent to sample volumes and the filter of the analyzer, they determine what would be the factor. When you go not for standard but for a calibrator, especially when the fully automated chemistry analyzers are there, or even the semi-automated, please remember the calibrators which are almost like a live serum. Their concentration of analyte is lot specific, and one has to be very careful that you use the value of the lot. Many times we forget, we put in the value in the program as so many milligram percent, and the different lot of calibrator comes in, the value changes, and immediately the factor get disturbed. You're using old factor for the new absorbances of calibration. So please remember, especially when the calibrators are used, they are lot specific analyte values. As far as factors of kinetic reactions are concerned, the factor of kinetic reaction, apart from these two, that is reagent to sample volume and lot specific calibrator value, also depends on predetermined factor given by many manufacturers based on molar absorption. Molar absorption is extinction coefficient of coloring substance. Okay. Now, let's say, for example, when we have done the alkaline phosphatase, where we have used paranitrophenyl phosphate. Paranitrophenol is the one which is used in taking the absorbance. Now, what is absorbance of 1 molar solution of paranitrophenol is extinction coefficient of paranitrophenol. Similarly, in case of cholesterol or HDL cholesterol or LDL cholesterol or NADH in terms of UV kinetic chemistries, NADH, these coloring substance, whether they are, whichever the absorbance is measured upon, what is the molar absorption of that is given in the literature. They are available as a textbook and they are used as extinction coefficient, and 1 molar 1 micromole of substrate consumed or product formed per minute is 1 unit, wherein absorption of the molar concentration is important, called extinction coefficient. It's available for NADH. It's available for almost every product which is being measured into color chemistry. So remember, kinetic chemistry has many times, apart from the calibration, has a prefixed factor. Like in case of alkaline phosphatase, if you don't have a calibrator, you use the OD multiplication at 2720 is a fixed factor provided for a sample to reagent volume of 1000 microliter plus 20 microliter. Okay, at 405 nanometer. These are the kind of things which are important. We are trying to understand what is the factor. Okay, now let us see what is the science of getting the stable factor. This is what our
Sir,
problem.
can you please repeat this point, sir, again?
Sorry.
Molecular observation. Can you please repeat this point again, sir?
Okay, repeat this point. Fine.
Yeah.
सी जो फैक्टर है वो concentration divided by absorbance when you run the calibrator or standard as a test. I hope this part is understood well.
Yes, sir.
सारी दुनिया, सारी stable factor fluctuation, everything depends on this. Now, most important is you can't change the calibrator value or standard value, but you can get a stable OD every time when you run the test. ओके द होल हमारी पूरी पूरी जो चीज है वो उस एब्जॉर्बेंस को पाने की है, दैट राइट एब्जॉर्बेंस. तो वी कैन ओनली फोकस ऑन गेटिंग द राइट एब्जॉर्बेंस. वो एब्जॉर्बेंस किस चीज पे डिपेंड कर रही है? वो डिपेंड कर रही है कि सैंपल वॉल्यूम, रिएजेंट वॉल्यूम कितना है, इंस्ट्रूमेंट का वेवलेंथ जो है वो, या फिल्टर जो है वो कौन सा है. इन दो चीजों पे वो डिटरमाइन कर रही है. तो हमको अगर फिक्स्ड फैक्टर लाना है तो वी हैव टू कॉन्सेंट्रेट ओनली ऑन दीज टू एरियाज दैट वी गेट द राइट अब्जॉर्बेंस फॉर द सैंपल टू reagent रेशियो recommended. Okay, so now we come to the factor depends on reagent to sample volume, calibrator concentration is lot specific, and factor of kinetic chemistry is predetermined and given in the technical IFU of the product. Okay, our whole valor or let's say prowess और हमारी होशियारी सारी इसी चीज पे है कि how do we get the right OD. If we get fluctuating OD, there is a problem. If we get a stable OD, we are minimizing the wastage and every result we report is reproducible and acceptable in the market. Okay, so how to get the stable factor? That means how to get the stable OD or right OD every time. Okay, in both endpoint and kinetic chemistry. Let's understand again. Factor is concentration divided by absorbance of the calibrator or a standard. First fundamental fact. Number two, absorbance depends on the stability value of the standard and cal. Okay, now apart from the absorbance, we will come to the absorbance again, but let's take first thing is that जहां पे सारी problems खड़ी होती है, the standard provided by the manufacturer or the calibrator provided by the manufacturer has a certain value. How we are able to maintain that value as a stable value. Okay. Now, let me give you certain examples in this is that when we take glucose standard, we are doing pipetting of glucose standard by putting some 10 microliter, 5 microliter, 20 microliter, depends on the analyzer specificity, in which we are putting a tip in the standard. If suppose by putting repeatedly the tip, which is slightly touching the reagent while dispensing and goes back into this concentration, the standard vial, with the time standard values will go on decreasing. That is one area. Second area is suppose when I'm doing the calibrator or a standard, I keep the vial open for some time. Some of the liquid will evaporate, making the standard as a concentrated one now. Instead of 100 milligram, it will become 101 milligram, 102 milligram, depending upon the time and temperature of exposure. Sometimes we may even forget to keep the entire reagent set into the refrigerator in the evening. Vial is open. वो खुली हुई standard vials में से concentration is going to be different in the morning tomorrow. अगर calibrator है तो problem और ज्यादा बड़ी है. Calibrator is they are almost like a live serum. they are having a special and determined values which are given by the manufacturer. ये serum is prone to bacterial growth. Although there are preservatives, everything, but कुछ न कुछ तो उसके अंदर लगता ही है. ये कैलिब्रेटर के अंदर इस एनालाइट का एक लाइफ होता है 2 दिन, 4 दिन, 5 दिन, 2 days, 3 days, or 4 days, depending upon the manufacturer and the claim, and depending upon the analyte also. Like bilirubin, highly unstable, stable only for 2 days, light sensitive. Glucose, stable for a long period of time, or there are enzymes which degrade with the time. So you have to make sure that you get the calibrator value of the analyte as far as possible stable for you. There is a science of it. If it's a serum, store it in the refrigerator, use it within the expiry period of that calibrator reconstitution life. If it's a standard, then it is a longer stability, but then ensure that it doesn't evaporate by contamination. It does not change its value, that the reagents are put inside. There are enzymes which keep on eating the glucose, and the glucose standard value or cholesterol standard value will keep on dropping down depending on how much exposure. तो हमको एक चीज का ध्यान रखना है कि हमारा स्टैंडर्ड, हमारा कैलिब्रेटर रिमेन स्टेबल फॉर इट्स वैल्यू. If its value is stable, absorbance will be stable. That is one fundamental value. Absorbance depends on the volume of standard and cal in the test. ये हमको बहुत ज्यादा ध्यान रखने की जरूरत है, because if suppose our pipette which we are using the calibrator for or standard for, and the pipette is not calibrated, different volumes are coming in, again absorbance will change, factor will change. Again we say, we re-emphasize that factor is concentration divided by absorbance. Absorbance depend upon the stability of the reagent. That means every reagent which we prepare has an auto-oxidation property. हमने alkaline phosphatase में ही देखा है, blank value keeps on increasing. ओके, अगर हमने कैलिब्रेटर लगाया तो हमारे को स्टार्टिंग पॉइंट ऑफ एब्जॉर्बेंस विल बी डिफरेंट. अगर ग्लूकोज है तो उसके अंदर या ओनली एंड पॉइंट केमिस्ट्री, ग्लूकोज, कोलेस्ट्रॉल और एनीथिंग, कैल्शियम, बिलिरुबिन, wherein the reaction with the coloring substance will give a certain OD plus the OD of the reagent itself will be measured. So it is important for us to ensure that the reagent blank is either stable or set to 0. हमारा जो स्टैंडर्ड का एब्जॉर्बेंस है वो 2 कारण से बदल सकता है. एक तो स्टैंडर्ड की खुद की वैल्यू बदल जाए बिकॉज ऑफ एक्सपोजर और कंटामिनेशन, या उसकी लाइफ ही शॉर्ट है और हम ज्यादा देर तक यूज कर रहे हैं उसको. ओके सर, लेट्स अंडरस्टैंड वन पार्ट. ये मैं हिंदी में वापस समझाता हूँ, बहुत इंपॉर्टेंट है ये, कि रिएजेंट ब्लैंक वो वक्त के साथ में इंक्रीज होता है, या अगर डिक्रीजिंग केमिस्ट्री है जैसे NaDH वगैरह तो उसके साथ में उसका रिएजेंट ब्लैंक डिक्रीज होता है. ये रिएजेंट ब्लैंक कंट्रीब्यूट्स टू द OD ऑफ द कैलिब्रेटर. हमको सिर्फ कलर ऑफ द स्टैंडर्ड और कैलिब्रेटर चाहिए, रिएजेंट की एब्जॉर्बेंस को हमको 0 मान के चलना है, वेदर इन द रेट, whether in absolute OD, in both the cases. So this is important for us to keep in mind that reagent blank contributes to the OD as far as the spectrophotometer is concerned or an analyzer is concerned. Okay. Now, why OD shifts every time? अगर मेरी pipette calibration में नहीं है, my pipette is not calibrated, sometimes it is delivering, let's say 10 microliter, sometimes it is 9.5, sometimes it is 10.2. So that is another problem where my fluctuation of the absorbance happens of the calibrator. Or my operator skills are different, a new operator has come in, he will change the calibrator or standard volume, resulting into change in absorbance, resulting into change in fluctuation factor, which is resulting into my results are not precise. So we have to take care that we keep our standard stable or calibrator stable, used within the expiry period of the cal. We have to ensure that every time the reagent blank do not contribute to the factor. We have to ensure that the volumes we deliver every time in the pipette is stable and precise, and we have to ensure that the operator is skilled and technically competent to perform the test every time. Okay, let's go ahead further. Absorbance also depends on the photometric performance of the analyzer, wherein the filter and the light source both are important. If filter keeps on getting dirty with the time, getting finger marks on the time, growth happens in the filter which are not which are gel based or something, or a light source, halogen lamp is fluctuating, halogen lamp is becoming weak, my absorbance of the cal will change, resulting into factor fluctuation. And if I'm keeping my factor old memory using the assay of today, my results are bound to be different. So keeping the factor is understanding and keeping the factor stable is important for any clinical chemistry test. Okay. I said very clearly electric supply. I remember one example very clearly is that when I went to Madras, that time now is a Chennai, and one distributor had gone to a customer's lab saying that there's a huge hue and cry about the reagent quality and all that. So I said, what did you analyze and solve the problem at? Oh, he had a simple power fluctuation in the plug which he was using. There was giving different power fluctuation, hence there was a erratic answers. See, these are very practical issues, and majority of the cases, problems of these kind, the solution is lying within the four wall of the customer premises, where you have to apply all your technical competency to understand what exactly is happening. Factors fluctuating, results fluctuating. Why fluctuating? Because of operator, because of the pipette, because of the photometric characteristics, or because of the reagent turbidity or color development. We have to find it out. Okay. Now, absorbance we have talked about. Let's talk about the results. How to get acceptable results in endpoint and kinetic chemistry both. What is acceptable results? Let's define. Acceptable results means when it is a control serum, it's a mean value plus minus 2 standard deviation is a standard deviation of the matching method. Okay, it's very important that you have a calcium value using arsenaz 03, and the value mentioned is ISE electrode, different methods. So ensure that you have a mean value plus minus 2 standard deviation of the matching method is your one acceptable criteria of the results. Second one, your results are matching with the standard reference method which they're using. Okay. Some of them are using, in case of HDL cholesterol, they use density gradient centrifugation and the value derived from that as the reference, and your phosphotungstic acid method or direct HDL method based on selective ion selective solubilizers or density specific solubilizers, their method, the results must match with the reference method. That is again another criteria of acceptable results means. Another one is, who is the ultimate boss? When you report a results go to a doctor, as a report of the pathology examination. Doctor expects and accept, yes, my patient history, my patient's diagnosis, this is what is matching to the symptoms of the patient. So your results and lab reports are acceptable to me. That's another criteria. Or sometime even in the patient history. Okay, last time his value was this, now the value is this, or the value by that lab is this, my lab is this. Again, an acceptable results criteria. Okay, so many of the cases, if your reports or results are not matching, one of the four criteria is not meeting. Hence, acceptable results, please match in these four parameters. Okay, now you as the reagent standardization in a customer laboratory, what is your best confidence? Your best confidence is your third party control serum, because the customer might tell you that this patient has come, this is the value, but I found last time it was this value, or from another lab it is this value, or he says it is this value. Sir, I don't know anything. Let me first run my control serum. If my control serum, by using the entire lab setup of yours, giving me the acceptable results using the right method, my confidence is high that my entire report system is perfect. We have to question something else, somewhere else, the history, reference value, another company's report. My control serum is best, my confidence is high. Next one, if I run my daily QC means if a normal sample, if an abnormal sample, I run them on a daily basis and plot a leveraging chart. My control serum value is good today, good yesterday, good day for yesterday, is going to be good tomorrow and day after tomorrow. Hence, my confidence in my reporting of the results is perfect, sir. You cannot question me on that. You have to accept, or you have to find out whatever your objections are, something else is the reason for it. Another confidence level comes in from participation in external quality assessment programs. Equas, they call it as. Randox runs it, Biorad runs it. They provide uh, around 12 vials of lyophilized serum samples, and they request you to dissolve in certain amount of volume on particular date. Everybody in the world who is participating in this program reports their results, and mean is drawn from that value. And how close is your mean to the rest of the world's mean? They don't even believe in what is the value. They said, in your community, using your methodology, this is what the mean everybody is getting, and you are within the plus minus 2 SD of that mean. Again, your confidence increases. See, important for us to know, मेरा रिजल्ट्स कितना एक्यूरेट है, इट डिपेंड्स ऑन ए थर्ड पार्टी जिसकी वैल्यू मुझे मालूम है और वो मुझे मिल रही है. बाकी सब चीजें परफेक्ट होनी चाहिए इफ दिस इज करेक्ट. ओके. Then another important issue is matching the precision value, that is percentage CV claimed by the manufacturer. Okay, most of the manufacturer जो भी हमको reagent देते हैं वो एक पर्टिकुलर नॉर्मल और एक पर्टिकुलर एबनॉर्मल सैंपल को 10 या 20 बार रिपीट करते हैं और उसका मीन वैल्यू, स्टैंडर्ड डेविएशन एंड स्टैंडर्ड डेविएशन डिवाइडेड बाय द मीन विच इज कॉल्ड परसेंटेज कोफिशिएंट ऑफ वेरिएशन, ये वैल्यू हमको मिलती. इफ दिस मीन कोफिशिएंट ऑफ वेरिएशन is less than 5%, that means my results are more or less repeatable. मैं आज जो रिपीट कर रहा हूं उसी पेशेंट का कल अगर मुझे सीरम दे दिया जाएगा, आई विल गिव यू ऑलमोस्ट द सेम रिजल्ट्स. My lab repeatability, precision value is high, my reagent setup is high, my pipetting is good, my analyzer is stable, I'm getting the highly precise results. That's your confidence, acceptable results matching criteria. Okay. And another very important thing and good thing which I find is when a lab is run by technicians, the owner is, or the doctor or pathology in charge of a large hospital, the boss of the department is sitting in some corner. He doesn't know what the fellow in the lab is doing. What he will do is, while the samples are coming in for the analysis, one particular sample, he will give it as a control and say, this is the patient sample. He knows which number is that. And he asks the entire team of the analysis team to analyze all samples. This is known value sample put at the blind interval. No one knows what number is that. You are supposed to analyze all 100 samples, 50 samples given to you. And he will ask you, okay, tell me the value of 37 number sample for this parameter. Okay, here is the value. He will see in levigening or in the control serum chart, if this is matching, if this is perfect, all other results are perfect. This is the way one can go into finding the acceptable results confidence. Okay. Now, sir, we take some more. Use the method recommended in IFU. Most of the time, the errors are mentioned errors are made in the laboratory not following the program parameters. कभी wavelength गलत है, कभी bichromatic not used, monochromatic used in response to what is the program given by the manufacturer. Sometimes it is the old calibrator value is there in the analyzer and you have changed the lot and your values are different. So please ensure that the program is perfect as per the manufacturer's recommendation. Please ensure that your pipette calibration validity is within the period, because every pipette when you calibrate, there are number of procedures. Even we have procedures for pipette calibration, and we are happy to share it with many people because ISO 9000 as the procedure, it's a gravimetric based. So pipette calibration validity, if it is defined for 2 months, it should be used within 2 months. After the 2 months, again, you have to calibrate and ensure that your volumes are right. Volumes are repeatable by pipetting. Another important, ensure that your analyzer is calibrated on a yearly basis. This is done by two different methods. One is optical density measurement using potassium dichromate reagents. There are standard solutions, WHO approved methods are available, that this many grams of potassium dichromate, you take it and measure the absorbance at 350 nanometers. This is the linearity of the various solutions obtained. Or else there are agencies which come with the chromium oxide filter. They put it in the analyzer as a sample and they run the entire absorbance spectrum. They realize which filter, which factor, or which value at which your stability of the OD is perfect. So it's a analyzer calibrations that is within the period and should be done. I recommend should be done once in a year. Then important is your serum or plasma or CSF should be the one which is recommended for the test. Type, time, storage, identification label. Okay, let's take one at a time. Type. Let's say for finding out the sugar, it is a fluoride bulb recommended. You are using EDTA bulb. By the time the separation happened, some amount of glucose is being eaten by the RBC and you get a different value. Take a second example, time. Bilirubin is to be estimated as far as possible within the same day when you are collecting the serum. And the serum is 2 days old and lying at laboratory bench in a tube, open under sunlight or tube light. The value of bilirubin is going to fall. You will not get the right results. Okay. If the serum is required to be stored at minus 20 degrees centigrade for 3 days for testing, and you have stored it at 2 to 8 degree only and testing the SGPT on 7th day, not going to give you the right results. Most common error happens is the control serum normal is labeled as abnormal, abnormal is labeled as normal, patient's identification label has changed, and you know this value should come, but the sample has exchanged its identity. These are common, simple errors. Sir, I will tell you one example, the wrong type of sample. Once in Ahmedabad, in some big government hospital, they were doing SGPT and they're saying the results are so hugely fluctuating. I said, let me go and find out. I found they were doing the test perfectly all right. But when I went to see, okay, today's sample I want to test and I want to see whether the control and the sample both are giving all right results. I went to the place where to pick up the sample, and the sample was being centrifuged by a fourth grade peon, and he had to go home early. He was centrifuging the samples for 3 minutes. So, and that vial was coming with the all fibers on the top to bottom, with the gradient of RBCs from bottom to top. And the technician was picking from the center 50 microliter, not even 5, 50 microliter. And that 50 microliter has to have fibrin particles. They were giving fluctuation. These are small type of errors. So I say when results are not acceptable, when results are fluctuating, 99% of the cases, you have to get into the laboratory, put your sleeves up, see the procedure, find out what exactly is happening at the analyzer level, at the sample level, at the pipetting level, at the reagent level, at the operator level. To get consistency in the results, these factors have to be stabilized and standardized. I said very clearly, the trained and qualified operators are only allowed. Many times they have a night shift. Night shift fellow is not fully trained. He runs the test. The reports are absolutely out of uh, acceptable mark and reported to the company saying that your agents are no good. Who has analyzed what time? Is he having qualification? Has he used entire precautions of warming up the analyzer? Pipettes were calibrated and found out that operator was new. At times it happens. Okay. And I said this before also, ensure the analyzer is programmed as required, especially the factor or calibration standard value according to its batch number. This is most common error I've found. HDL cholesterol calibrator value is 63. He is running and he is finding results are getting out because new lot of calibrator has been running and that is having a value of 67 calibrated as 63 in the previous program. Common error. Sir, this is regarding the getting a standard, stable factor and accurate answers. Certain insights of this. Okay. Now let's wind up this knowledge also. We'll get into the third one. I hope Tiwari sir, I'm in the time or am I crossing the time?
It's okay, sir. We all are enjoying. It's okay, no problem, sir. Crossing the time is also not an issue, sir.
Okay, sir. So now another big problem. Creatinine का result stable नहीं आता है. Most of the time the creatinine results are fluctuating too much. Okay. Let's address this third common problem. मुझे समझ में आता है क्रिएटिनिन का रिजल्ट्स क्यों एक्यूरेट होना चाहिए. For those who are new, let's understand one simple thing. अगर किसी पेशेंट का किडनी ट्रांसप्लांट हुआ है, उसका क्रिएटिनिन every 1 hour will be tested whether the kidney is getting rejected or accepted by the patient. Every minute value, if it is in one direction of increasing side, immediately they understand this kidney is getting rejected because creatinine value is increasing. Or if it is stable, then it is important to understand very clearly that kidney is accepted. ये scenario number 1 where there is a transplant and criticality of creatinine value. दूसरी चीज है, if there are people with the some kind of a pathology in diabetes, some kind of pathology in some other functions, liver functions, and if they say my creatinine value is not meeting the acceptable range, the person start getting anxious whether my kidney is functioning all right or not. So the results are critical and their values are 1 and 2 milligrams only. The fluctuation is alarming to them. So let's take this. ये क्रेटिनिन का रिजल्ट्स बार बार गलत क्यों आता है? सर, creatinine is estimated as 2-point kinetic reaction. There's another type which is a free time kinetic reaction which is used in SGOT, SGPT, etc. etc. लेकिन ये 2-point kinetics. Why 2-point kinetics? That is where the entire creatinine reactions reproducibility comes into the picture. First fundamental point, which I'll repeat it 3 times. Creatinine की reaction एनालाइजर के एस्पिरेट बटन से नहीं स्टार्ट होती है. It starts when the sample is mixed with the reagent. Fundamental point. Let's keep this in mind, and as a thumb rule, God's statement. Reaction starts when reagent is mixed with the sample. Sample mixing किया, reaction started. Keep it in mind. बार बार ये आएगा. This is your 0 point time, not the aspiration button in the analyzer. Keep this as a thumb rule. जहां जहां जिसने इस पॉइंट को समझ लिया है, उन उन लोगों के क्रेटिनिन के सेल्स बढ़ गए हैं बिकॉज कस्टमर कंप्लेंट्स हैव रिड्यूस्ड. Let's take the third point. When do you take the first absorbance? 30th second. I'm talking about alkaline picoret reagent. It's not nothing to do with the enzymatic creatinine. ज्यादातर कंट्री में alkaline picoret reagent ही यूज हो रहा है. So the first absorbance happened at 30th second. This 30th second starts from where? Not from the aspiration button. It starts from the sample addition. Okay, fundamental, absolute fundamental point to note when reagent and sample is mixed. Now problem happens. Absorbance first, 30th second from the sample and reagent mixed. This is called delay as per IFU. Confusion starts here only. हम बोलते हैं डिले प्रोग्रामिंग शुड बी 30 seconds. We program semi-auto analyzer, fully auto analyzer as per this. Okay. Now this 30th second is the 0 second in analyzer programming when you aspirate the button. But reaction, has started long before when you added sample. Now, how do you solve this problem? You have absolutely no idea that 0 will start when you do pipetting. और आपका एनालाइजर में रिएक्शन स्टार्ट हो गया, नहीं होता है. Reaction has a starting point only when the aspiration button is pressed. So now manually keep, okay, at 60th second in my watch, I have added sample to the reagent. 15 seconds I'll allow to mix, go to the aspiration tube and wait. At the 50th or 15th second, I'll press the aspirate button, or 20th second. That should be fixed. जिसने ये काम किया है उनके क्रिएटिनिन के रिजल्ट सही आने लग गए, अपार्ट फ्रॉम मेनी अदर थिंग्स व्हिच विल डिस्कस ओवर अ पीरियड ऑफ टाइम. नाउ ये फंडामेंटल सक्सेस स्टोरी whenever it has been implemented, because in Accurex we had 105 sales guys and these sales people were complaining about the alkaline creatinine results being fluctuating. I said ये छोटा सा एक काम करिएगा, आप घड़ी लगा के सैंपल एडिशन करिए 15 सेकंड के ऊपर. जैसे 15 सेकंड हैपेंस, प्रेस द एस्पिरेट बटन, द प्रोग्राम विल स्टार्ट कैलकुलेटिंग 30 सेकंड फ्रॉम देयर ऑनवर्ड्स. बट ये पॉइंट फिक्स हो गया. ओके, दिस इज मोर इंपॉर्टेंट, वेरी वेरी इंपॉर्टेंट. ओके, लेट्स टेक वन पॉइंट अहेड. सेकंड रीडिंग ऑटोमेटिकली एनालाइजर विल डिसाइड अगर आपने रीडिंग टाइम 60 सेकंड्स दिया है या सेकंड एब्जॉर्बेंस एट 90th सेकंड, तो 60 सेकंड्स का गैप. But again, remember, 0 second was the sample addition, not the aspirate button. Ensure that this happens. This is, I said very clearly, as per the time recommended in IFU, 60 second is the read time or 90th second is the second absorbance. Nowadays, it's a time of era where the analyzers take more of read time rather than the absorbance, number of absorbance and interval. That is not more or less valid now. Most of the analyzers in the olden time, it was not that graph always visible, but now those new analyzers have a graph. Then read time should be 60 seconds. Absorbance is changing during the read time is called reaction speed. Just remember this as a fact कि जैसे ही sample reagent mix हुआ है, reaction has started, orange color has started becoming darker and darker. That is the reaction speed. But remember, the reaction speed here is substrate concentration dependent. What is the substrate in this? Picric acid is the substrate. Concentration of picric acid is becoming darker and darker as a complex. With the time, concentration की value decrease होती जा रही है. So substrate concentration is changing during the reading time. This is a very fundamental critical observation, and hence your rate of absorbance is also changing. I'm saying not absorbance, absorbance will change, but the speed at which the absorbance will change, delta absorbance, is also becoming different every time. The reason is was substrate concentration dependent, which is a changing time. मैं इसको हिंदी में रिपीट करूंगा। हमारा रिएक्शन के अंदर एब्जॉर्बेंस चेंज होता है, अल्कलाइन पिक्रेट रिएक्ट्स विद द क्रिएटिनिन और वो एक कॉम्प्लेक्स बनता है। ये कॉम्प्लेक्स की जो बनने की स्पीड है वो अल्कलाइन पिक्रेट के कॉन्सेंट्रेशन डिपेंडेंट है। ये कॉन्सेंट्रेशन जैसे जैसे रिएक्शन आगे प्रोसीड होती है ये कॉन्सेंट्रेशन बदलता है, इसीलिए इसका डेल्टा एब्जॉर्बेंस की स्पीड भी बदलती है। दिस इज अ यूनिक issue with two chemistries. One is creatinine, another one is blood urea nitrogen or BUN or urea by the UV kinetic method, where kinetic reactions are used to find out the analyte rather than enzymes. तो यहाँ पे ये चीज होना ही होना है। This yellow line is important to notice कि rate of change in absorbance is also changing. Not only absorbance changing, rate is also changing. That is why absorbance 1 and absorbance 2 time points are to be fixed. अगर वो 60 seconds है तो 60 seconds है, 65 नहीं हो सकता। For sample and calibrated differently, it has to be same for both of them because हमको हमारे pattern of parabolic reaction ये proportionality लानी है स्टैंडर्ड में और सैंपल में। ये टाइमिंग अगर हमने बदल दी है तो द स्पीड विल चेंज एंड यू विल कंट्रीब्यूट टू द रिजल्ट्स। कि रिजल्ट स्टेबल नहीं है, आपका स्पीड बार बार बदल रहा है, रीजन योर टाइमिंग्स आर चेंजेस। सो एंश्योर sample addition is 0 second, 15th second is aspiration button, 30 seconds, that means 15 plus 30, 45 second it will take the first reading, and for consecutive next 60 second will keep on taking the reading as these two functions of first reading and second reading is governed by the analyzer, but sample to addition to reagent addition and pressing aspiration button you need to standardize। जिसने ये किया है कस्टमर प्रेमाइसेस में उनके रिजल्ट्स रिप्रोड्यूसिबल आने शुरू हो गए। So these points are fixed and they are to be fixed for the same should be for sample as well as calibrator or standard. So I say very clearly that absorbance 1 and absorbance 2 time point has to be same for cal and sample reaction। हमारा प्रोग्राम स्टैंड कैलिब्रेशन के टाइम पे अलग था, बाद में अलग हो गया, या सैंपल ऐड करने के बाद में एनालाइजर का एस्पिरेशन बटन दबाने के बीच में कभी 15 सेकंड का गैप है, कभी 20 सेकंड का, कभी 10 ही सेकंड में हुआ, कभी 5 ही सेकंड में हुआ। दैट वेरिएशन इज बाउंड टू गिव यू डिफरेंट आंसर्स बिकॉज योर कैलिब्रेशन एंड सैंपल आर रन इन टू डिफरेंट स्पीड ऑफ ग्राफ। It's important that you maintain this same. I repeat, I have written it in the red that these points should be same. And again, I repeat, sample addition should be considered as the 0 and 15 seconds should be the time you press the aspiration button in the analyzer if it is a semi-automatic. If it is not semi, it is a fully, these are taken care of by the analyzer itself. Factor calculation of creatinine is dependent on these two time point during the reaction. It's very, very critical and important. हमारा पूरा फैक्टर ही इस दो टाइम पॉइंट पर डिपेंडेंट है। अगर ये टाइम पॉइंट अलग हुए फैक्टर बार बार बदलेगा। अब इंपॉर्टेंट इज ये क्रेटिनिन वैल्यू है होती कितनी है? इट्स जस्ट 1 or 2 milligrams। And there also, if you do changes in your factor, the results are in percentage wise is a big mess. Another important thing, you notice this creatinine is run for big sample volume, which is not 5 or 10 microliter, it is 50 microliter. Relatively in today's scenario where 2 and 3 and 5 microliter are used for doing the chemistry in creatinine, it is used 50 microliter because reaction speed is not too big. It's a big sample volume. Absorbance at 90th second is very critical from the reagent mix point of view. कभी कभी लोग स्पेक्ट्रोफोटोमीटर में घड़ी लगा के भी estimation करते हैं। It's very important that you have to keep your watch very stable and the same time should be calibrator and sample done. And read time is as per IFU 60 seconds, which I have said number of times. Okay, another factor in the line which is high concentration of interfering substances in a high sample volume. You are carrying 50 microliter sample per 1 ml of reagent or 25 microliter for 500 microliter, which is normally used in semi-auto, and auto analyzer has a little lesser volume, but sample volume comparatively to other analyzer, other analysis, it is high, means high interfering substances also. Which ones? Protein interferes, glucose interferes, hemoglobin interferes, bilirubin interferes. They all interfere in the speed of reaction where creatinine is binding with alkaline picrate to form an orange color complex. Now, this is a big problem. You can't reduce, you can't deproteinize the sample, you can't reduce the glucose, hemoglobin, bilirubin, etc. Little extra precaution you can take it is don't use hemolyzed sample, don't use ecteric sample. But what about those people jinko hemoglobin and bilirubin is present in the high volume in the blood on the serum and they want to do their kidney test? They have to be used. So what is the answer in this case? Answer is alkaline picrate reagent should not be used, which are reagent based on saturated, because saturated alkaline picrate will have all these problems. But where there is an alkaline picrate reagent, saturated has the problem. Okay, we have optimized. See the line alkaline picrate reagent of creatinine has to be optimized, not saturated. The companies who have technology to optimize the level. Optimization happens by measuring the absorbance, and if it is more than the limit, the reagent has to be diluted in such a way that you get the optimized picrate value. There you reduce the possibility of interfering substances. Okay. I hope I've been able to address these 3 points. Yaswant sir, now it is question and answer session.
Yes,
And
sir. Yes, sir.
yeah, so I have taken up the 3 points, although I have probably crossed 1 hour, 15 minutes longer than usual. But for me is also first time, so that I've been very slow. But I leave it to you. What is the question which you want to take it as?
So let us request the participants to raise their questions. They may put their questions in chat box.
Okay.
Right from the beginning of my career, I have been taught right from the first day of the training
Mhm.
in IVD. All reagents are to be, working reagent has to be at room temperature RT, whereas they should be stored at 2 to 8 degrees centigrade. Why can't
Correct.
I store them in freezer?
Abhi, once you put it in the deep freezer, all the
Yes,
reagents are basically liquids,
yes,
which
sir.
means 99% is the water.
Yes, sir.
Okay, once you put it in the deep freezer, the water will freeze, forming icicles,
Yes, sir.
ice crystals, icicles.
Yes, sir.
These icicles, when they melt, while
Yes.
you bring them to room temperature,
Yes.
many times in the reagent, they kill enzymes.
Oh, oh, yes. Yes, sir.
Yes,
Let's
yes,
say
yes.
let's say, sir, I remember one case very clearly in Delhi where a person saying that your glucose reagent is there was an accuracy that the reagent of glucose is not developing any color.
Okay, sir.
So I said, how can it happen? Glucose reagent not developing any color. Is the blank very high? Has the color discolored or something? No, blanks are very good.
Yes, sir.
I said, now let me visit your lab. I
Okay, sir.
visited the lab. He brought the sample, a reagent from the deep freezer.
Okay, sir.
I said, why in the deep freezer? Sir, we had last 4 days holidays. So I thought we will arrest the blank of the reagent in the deep freezer. So we brought the deep freezer reagent into, let it melt. I said, sir, this will reagent will not work.
Yeah.
Okay, sir, let me say very clearly is that glucose oxidase
Yes,
has
sir.
been totally denatured by freezing and thawing.
Yes, sir. Okay, sir.
Okay, so not all enzymes are stable. That is one reason. Number two, when you want to use it, when you have a deep freezer reagent and you want to use it, you keep it at the room temperature for some time.
Yes, sir.
उस टाइम के ऊपर आपका melting creates a density gradient in the reagent.
Oh, yes, sir.
From the top, it will be thin reagent, bottom will be thick reagent. Sir,
Okay. So
even
which reagent can be frozen, sir? Which
uh,
reagent can be frozen?
the reagent which can be directly used. Directly used in the sense, this, like for example, in alkaline phosphatase, we said that you can defreeze your reagent.
Yes, sir.
Defreeze means what? If you are suppose you are doing 500 microliter
Correct.
every test, you
Yes, sir.
divide your reagent into 500 microliter, put in the defreezer, you bring it out.
Okay, sir.
Entire 500 microliter, you add the sample, mix it, and run the test.
Okay, sir.
So gradient formation, not formation. Once you add sample, mix it, everything is same.
Okay, sir.
So aliquoting and
Yes.
freezing to arrest the alkaline phosphatase blank. और बाकी reagent में भी, if suppose
Reagents without enzymes can be, you mean to say, sir?
without enzyme, तो certainly yes.
Okay, sir.
Enzymes में भी अगर आपको
हाँ.
मालूम है कि there are stabilizers added in the liquid reagent which make them freeze, thaw, resistant, you can
Okay,
use
sir.
them.
Okay, sir. बहुत बढ़िया, sir.
Right?
Sir, we have started receiving questions.
हाँ जी.
Sanjoy Datta, after running alkaline phosphatase in semi-auto, is it recommended to run wash solution to reduce the carryover or contamination?
So that is a basic fundamental question, is that when you have a corrosive reagent like alkaline picrate
Yes, sir.
or corrosive reagent like total protein,
Yes, sir.
one simple air bubble gap between two analytes, I mean
Yes,
two tests, is
yes.
not sufficient at times.
Okay, sir.
मैं तो ये recommend करूंगा कि whenever you run a very high value sample of one particular test,
Yes, sir.
rinse it with the water so
Okay, sir.
that little carryover of the previous value does not increase the value marginally in the next sample.
Okay, sir.
If it is too corrosive reagent or too high value sample.
Okay, sir.
Otherwise, the analyzer जिसका cuvette capacity is only 80 microliter to read.
Okay, sir.
We are taking into the aspiration around 450 microliter or 300 microliter. So it some of the initial portion washes off the cuvette reading area, goes into the tube beyond the reading point.
Yes, sir.
But sometime it is not possible.
Okay, sir.
Sometimes it is more corrosive reagent, more sticky cuvette, which has not been cleaned for a long time,
Yes, sir.
will have this carryover. It is always best to clean the cuvette and run the test.
Correct, sir. Correct,
Right,
sir.
sir. Next.
This Mr. Prahlad Paudyal, what are
Okay.
the way of generating factor for different method?
Sir, I did not get the question. What are the ways of generating?
Generating factor for different methods.
Okay, what are the ways of generating factor for? Sir, factor for different method, don't commonalize it.
Okay.
It is individual case to individual case.
Okay, sir.
Whenever you run the test, and if you are not confident that your photometrics of the analyzer or the pipette or the operator is same, best is run and re-establish the factor.
Okay, sir.
And for different reagents, separate factor. One factor of one chemistry cannot be used in another one because altogether this is a different
Okay.
systems completely. So is the best is run a calibrator
Okay.
which is known value and stable
Okay,
with
sir.
the perfect ideal condition of running,
Okay,
and observe the absorbance value, and either you calculate the factor or the analyzer calculates the factor,
great, sir.
but keep
Great.
it in the memory.
Okay, sir.
The best practice is always to, write down the factor which you have been getting.
Correct, sir. Correct, sir. Correct.
Okay.
Yes,
That
sir.
will give you a consistency. Okay, yesterday I've done GPT, I got this factor. Today I've done the GPT, I've got this factor. Every time I'm drawing this is the range in which I'm getting my factor at.
Okay,
Okay,
sir.
it's the best practice always.
Okay, great, sir. Great, sir.
Yes, sir.
Sir, Mr. Pradeep Kumar is asking, in semi-automatic biochemistry analyzer, when I perform calibration of CRP, it looks good graph. Is also good, but when run patient sample graph is straight line means no reaction. How sort out this? How to sort out this problem?
Okay, in CRP, CRP is an increasing kinetics. He's
Yes.
saying straight line means no reactions.
Correct.
Okay. That means either the patient value is very, very low
Okay.
and instrument fluctuation is overpowering that.
Okay.
That means he will get a simple straight line, but it looks samples to be the best way is, sir, run a control.
Okay, sir.
Run
Will
a control. If you get your controls all right with the graph all right, which is saying already that it is happening. When I perform calibration CRP, it looks good graph. He's saying very clearly that the graph is good. Calibration is running well and the patient sample is almost running straight. That means patient CRP value is very low. You know what is CRP value of the patient is? 1 milligram, 2 milligram.
Hmm. Yes, sir.
Calibrators of the CRP are normally, I repeat, normally they are 60 milligrams,
Okay.
60.
Hmm. Very true.
You can verify those who are
Yes, sir. Yes,
listening to this. CRP normally calibrators are 50, 60 milligrams,
sir.
and
Yes, sir.
patient value is 1 and 2 milligrams. So
Correct.
obviously, it's bound to look flat.
Okay.
Okay, this is what my observation. That could be something else also, but this is what I can
No
immediately feel.
problem, sir.
Yes.
I think he got the answer. There is a Rashmi. Why the results vary from one machine to another machine, from analyzer to analyzer? Why the results vary? Her question is very simple.
Uh, Rashmi madam, I was explained very clearly is that analyzer to analyzer, the results vary. Okay, results. It's not, she's not talking about the factor. It's results. Okay.
Okay.
Now what happens is analyzer to analyzer calibration varies.
Yes, sir.
Okay. People do calibration in one analyzer at one point of time, and
Yes, sir.
over a period of time, the reagent has developed the color
Correct,
and
sir.
they are running the test. When they are running the test, they are developing a color of a patient value. Okay.
Correct, sir.
Now that patient value also has the reagent color giving higher results.
Correct, sir.
Another analyzer, the
Huh.
factor may have been established afresh, where
Yes, sir.
the reagent absorbance contribution towards the patient value is zero,
Yes, sir.
and you are comparing the two results. That
Well,
could be one. Second is every filter of an analyzer.
yes,
Sir,
sir.
I repeat, every filter of an analyzer has a bandwidth.
Okay.
Bandwidth means if suppose I say this filter is 505 nanometer,
Yes, sir.
is it 505 only or 504 and 506 also?
Okay, sir. Yes, sir.
Is it 500 and 510 also?
Okay, sir.
So these filters are different wavelength bandwidth.
Yes, sir.
Okay, these bandwidth. That is why I say you re-establish your factor every time when you run the test
Yes, sir.
and run the control. If you do these two things,
Yes,
your
sir.
confidence in the results is very strong.
Yes, sir.
Okay.
Yes, sir.
I hope Rashmi is satisfied with the answer.
She should be.
Calibration run and control serum value match.
Sir, one question from my side again.
Okay.
It was regarding CRP only. What
Uh,
problems will come up if the values are very high for CRP, sir?
okay. Sir, CRP you are asking, or in fact, I'll tell this general question.
Yes, sir.
The values are very high in any analyte.
Yes, sir.
Let me take it as any analyte.
Yes, sir.
We know there is a there is a sensitivity of the reagent
Yes, sir.
and there is a linearity of the reagent. These two things are fixed and mentioned in IFU of every
Yes, sir.
reagent system.
Yes, sir.
Sensitivity is the lowest value you can detect, and linearity is the highest value you can detect, where there is a confidence and accuracy.
Correct, sir.
Okay. Now, high concentration, if it is beyond the linearity limit of the reagent, it
Yes, sir.
has to be diluted and reused. Because why there is no linearity of the answer when you increase the concentration? Because either reagents become limited
Okay.
or optical density goes so high that the analyzer measuring capacity gets limited.
Okay, sir. Correct, sir. Very true.
So whether it's a CRP, whether it is GPT, GOT, whether it is alkaline phosphatase, whether it is any other reagent beyond linearity limit,
Okay, sir.
You have to be careful that if you dilute and multiply the results by, if you, whatever the dilution factor is, if you have
Correct.
diluted serum by 2,
True, true, sir.
I'll just give you an example again, since you asked a very important question. It's important to many people that people used to determine glucose value initial days, and glucose values for the diabetics were crossing 500 milligram, 500, 600 milligram.
Yes, sir.
And the reagent systems of those times, especially Fallenbu or other ones, which are not applicable now, but they were not able to estimate anything beyond 300 milligram per set.
Hmm.
Okay. Now, we had to incorporate a 300 milligram standard in the reagent system in Accurex. The reason simple that if you have a confidence up to 300,
Huh.
your results are dependable. If you are not able to find 300 as the real answer of 300 and you're getting around 150, 200 only, that means all highly diabetic people, you are reporting normal value or marginally high diabetic.
Correct, sir.
In case of liver cirrhosis,
Yes, sir.
when GPT and GOT values are very high,
Yes, sir.
almost like 3,000, 4,000 international units per liter,
Correct, sir.
in the first 60 seconds of testing,
Yes, sir.
they will consume the entire NADH.
Yes, sir. Yes. Very true.
They will fall down below 0.5 OD, even
Yes.
the first reading.
Yes.
And you assume that this first reading 0.5 and 3,000 units, they will be able to estimate. They will report value as 30 and 40 international unit for a patient who is having highly infective liver cirrhosis.
Oh, yes, sir. Yes. Correct, sir.
And this was a very big major issues in the initial period when I used to travel into the field. Many labs, when they were reporting, oh, value is GPT, GOT is 30 and 40. My
Oh,
clinician is not accepting. He is having problem in the patient.
correct, sir. Correct,
Okay,
sir.
just look at your reagents reaction graph.
Yes, sir.
Is it starting with 1.0 OD and above, or it is starting below that?
Okay, sir.
It is starting 0.5. Okay, how do you expect? Substrate is already over in
Very,
first 60 seconds itself,
very, sir.
even
Very.
before you have taken the first reading.
Yes, sir.
So it's important that you study the graph. Graph also is like a Janam Patri of a reagent.
Correct, sir. Very true. Very true.
अगर आप उसको पढ़ना आता है तो you will be able to say very clearly, no, this has to be diluted. It's very high value, looking and showing normal.
Yes, sir. Yes, sir.
So high value samples, आपको बहुत ध्यान देना पड़ेगा linearity and reagent graph pattern.
Bilkul, sir. Bilkul, sir. Sir,
Yes.
there are 8 more questions. Thereafter, I have one question that I will ask at the my question will be the last question.
Okay.
8 questions.
Okay.
Mr. Ranganathan,
हाँ.
what is the recommended calibration frequency for creatinine test? If a lab has a creatinine sample load of 50 plus samples or a normal lab with a daily 5, 10 or creatinine sample load, calibration frequency for less workload and high workload. This is what he means. He means.
Okay. So he is asking what is the recommended calibration of creatinine test. Okay, you're saying frequency.
Yeah, frequency. Calibration frequency because
Sir, very, very important, very easy question.
yes, sir.
Run it daily.
Oh, great. Very good.
Run it daily. I'll explain it to you why.
Yes, sir.
Creatinine reagent is alkaline.
Yes, sir.
Alkaline reagent, when lying open, when
Yes,
you are running so many tests, and it is a kinetic, fixed time kinetic chemistry, every sample is taking 2 minutes.
oh, correct,
If
sir.
it's a 50 samples, 50 into 2,
100 minutes.
100 minutes. 100
Yes.
minutes plus the pipetting time.
Yes, sir. Yes, yes.
Almost for 2 hours, he's keeping the reagent open.
Yes, sir. Yes, sir.
Alkaline reagent, keeping it open, absorbs carbon dioxide from the atmosphere.
Oh, great. Yes, understood. Understood. I think it's clear to Mr. Ranganathan.
Okay.
Very true.
So, sir, I don't have to elaborate. Run it every time.
Yes, sir. Mr. Akshay,
Yeah.
many customers use hypochlorite for flow cell flushing or washing.
Huh.
Is the wash solution better or diluted hypochlorite is more effective?
Okay, sir. Let me explain it to you. I'll ask Mr. Rang
No, he is
Akshay
different.
Mangi.
Mr. Akshay.
Okay. What does hypochlorite do?
It is
Sir,
sodium
we all know very clearly
solution. Yeah.
hypochlorite disinfects.
Yes, sir.
Hypochlorite disinfects. Hypochlorite does not clean protein precipitate. Hypochlorite does not clean lipid deposits.
Yeah.
Hypochlorite is a good disinfectant.
Okay, sir. Great.
So to clean the flow cell, it is always better to use three functions. That is
Okay.
what I recommend my staff or many places. TAC, triple action cleaner. Triple
Oh,
action is disinfect, deproteinize, delipidize.
oh, great.
So these three
Yeah.
deposits, they are there on the flow cell. So the best thing is when there are flow cell cleaners available, they are basically surfactants.
Yes, sir.
And apart from the surfactant, they also have BKC, benzyl conium chloride, which disinfects it mildly.
Okay, sir.
So this is the best solution, surfactant, and a little alkaline also. The alkalinity removes the proteins,
Correct, sir.
surfactant removes lipids, and
Yes.
BKC, that is benzyl conium chloride,
Okay, sir.
disinfects the flow cell. And this is not only this, just in the every evening, just flush it inside the flow cell, keep it for 30 seconds for some time,
Okay.
shut the analyzer with this.
Okay. Great.
Whole night it will keep on cleaning the flow cell. Next
Yeah.
morning, flush it with a 5 ml of wash.
Oh, fantastic.
How to how to decide which wash reagent to buy?
Okay, which wash
Uh,
reagent? Okay, you are asking technical secrets. No problem, sir.
yes.
Akshay, it's very easy that BKC is available across the market, and you also have Triton X100. These are available in the market. 0.1% solution of Triton X100 with little BKC is the ideal solution to flush it in the flow cell so that it has a property of removing proteins, lipids, and disinfection both.
Great.
Right, sir?
Fantastic, sir.
Thank you so
Next
much, sir.
question is from, okay, Akshay. Next question is from Mr. Chettupalli. Sir,
Uh,
how to identify this reagent frozen or is it at 2 to 8 degree centigrade condition?
Sir, this is always mentioned on the bottle of the reagent
Okay, sir.
as a part of the label.
Ah,
Apart from that, additionally, you want to know whether 228 recommended and can be done at -20 degree. Also, it's a matter of you studying the property of the reagent and going into the Google search. But
okay.
otherwise, reagent storage temperature, there is a symbol on
Yes, sir.
every chemistry IFU
Yes,
where
sir.
there is a thermometer sign
Yes, sir.
and there is a line across where lowest and highest temperatures are mentioned in that.
Yes, sir. Yes, sir.
Okay. If suppose you can see this IFU,
Yes, sir.
where is it? Yes, you can see this
Yes, sir. Yes, a third line. Third
third,
line. Yes, sir.
third from the left side.
Yeah.
Okay. That is a symbol
Yes, sir.
which gives the temperature storage recommended.
Very true, sir.
Yes, sir.
Question from Birendra Nath.
Hmm.
Sometimes factors are acceptable, but results not match. Why?
Why? Okay. I'll give it to you. Most of the time they do, but sometimes yes.
Okay.
Okay. Now look at the chemistry. Chemistry like triglyceride, chemistry like cholesterol.
Correct.
Okay. Look at their principle. It happens in such chemistries.
Yes, sir.
In cholesterol, the first reaction which happens is cholesterol ester hydrolysis.
Okay.
But which is a 50% cholesterol esterified in the serum and 50%, almost 50% as a free cholesterol in the serum sample. But your cholesterol standard is starting from cholesterol.
Yes,
So
sir.
it bypasses the first enzyme.
Correct.
And if the reagent not having good quality where esterase function is diminished,
Okay.
factor will come all right, results will not.
Oh,
Results will probably come half.
okay.
Okay. What is the solution?
Uh,
I'll give you one more example, then I'll give you the solution. One more example is like triglyceride.
yes, sir.
Triglyceride, the standards are always glycerol based.
Yes, sir.
Okay. Now, where is the glycerol starting in the reaction? Triglyceride present in the serum sample.
Okay.
Lipase, yeah, lipoprotein lipase
Yes, sir.
degrades this triglyceride into free fatty acid and glycerol.
Yes, sir.
But the standard starts from glycerol. If lipase function in the reagent is uh, compromised, factor will be all right, the results will be low.
Oh, correct, sir.
Look at the principle mentioned in the mechanism of action. Where is the sample starting from? Where is the standard starting from? Answer to both of them.
Okay.
Don't depend on the standard provided by the kit. Go for a calibrator,
Okay, sir.
which is a serum-based calibrator. So the calibrator and the sample both will go through the same cycle of reaction
Okay, sir. Great.
involving entire reaction principle.
Fantastic, sir.
Right,
I
sir?
think Virendra must have understood it. The
Okay.
next question is from Ravikant Singh. With calcium, there is most of the time calibration and QC is okay, but there is a variation of sample results. Most of the time on lower side in fully automated analyzers.
Fully automated analyzer.
He
Okay.
has written FA. Yes, sir.
Ravikant, the common error of sampling in calcium is using EDTA bulb.
Okay.
Okay, you see all your anticoagulants,
Hmm.
they work on the basis of chelating calcium.
Yes, sir.
Okay, calcium is one of the factor for clotting of blood,
Yeah.
and anticoagulant tend to attack on calcium to bring it not having a coagulation but using this as a plasma thereafter. Okay, if plasma collected with chelating of calcium, the results are bound to be low. This chelating of calcium happens by citric acid, by oxalic acid, by EDTA. These are common anticoagulant which reduce the amount of calcium, and your standard is run well, your results are okay, but the sample is low results.
Okay.
Exactly, it is fitting in. So it is free, I mean, fully automated analyzer does not have any programming error. It is, I feel, the only wrong sample used here.
Okay. Great.
Check it on that area. Probably you'll find the answer there.
Sure, sure, sir. I think. Then Prahlad, in fully automated analyzer, how common is optics failure and what are the things to verify it? His
Okay.
question is pertaining to optics of fully automated analyzer.
Yeah, fully automated analyzer. Okay. Fully automated analyzer, they normally don't tend to use filters.
Correct.
They tend to use diffraction grating.
Yes, sir.
Diffraction grating is a principle in which a prism, a series of prism through which the light passes, and bands of the lights are separated, and the particular portion is selected for doing a selected test. Okay. Now, this diffraction grating tend to accumulate dust over it. The gain falls down,
Okay.
ODs falls down,
Okay.
and factors get affected. But how do you know what is happening to it? The best thing I would say is a regular calibration and servicing of the analyzer.
Hmm.
Secondly is if you use a dichromate solution,
Yeah.
potassium dichromate method.
Hmm.
Potassium dichromate can be prepared of 0.25 optical density, 0.5 optical density, 1.0 optical density, and 1.5 optical density. These optical densities are meant for at 340, 350 nanometer.
Yes.
Now, there is a possibility that you do not have the 350 nanometer in the analyzer, but you certainly have 340 nanometer, which are used for all the UV kinetic chemistry. Okay, you can run the
Yes.
potassium dichromate sample and record its absorbance.
Okay.
1.5 optical density may not give you 1.5, it might give you 1.3,
Correct.
but certainly it will not give you 0.5.
Very true.
If it is giving 0.5, 0.2, 0.3 and not linear,
Yeah.
your photometrics of the fully auto analyzer is compromised. Whether it is Spectrophotometer, I mean, fully automated is the best thing, because if the similar thing you do in the semi-auto, only 350 nanometer or 340 nanometer filter will be giving its health. What
Okay.
about 505, 546? The best thing there is chromium oxide filter. Chromium
Correct.
oxide is one filter which gives the bandwidth of entire wavelength range.
Great.
This calibration is a little expensive, but only professionals can do that. They bring their chromium oxide filter and do this.
Fantastic.
Right,
I
sir?
think Prahlad must have got the answer. Again, second question from Akshay.
Uh,
The stability of creatinine working reagent decreases quickly even when the R1 and R2 are kept separate. What recommendations can we give to the customers to maintain the better stability?
okay. R1 and R2 keeping it separate.
Yeah.
Normally, it's a room temperature chemistry.
Yes, sir.
Alkaline picrate or creatinine reagent is a room temperature stable chemistry.
Correct.
Sir, stability of creatinine working reagent. Okay, he's talking about working reagent.
Working reagent, yes.
Even when R1 and R2 kept separate. Sir, both the reagents, you know what is R1 and R2 in the alkaline picrate reagent system? R1 is nothing but sodium hydroxide solution
Okay.
of certain strength.
Okay.
Again, prone to open, keep it open and absorb carbon dioxide from the atmosphere. Picrate reagent, again alkaline,
Okay.
tend to absorb carbon dioxide from the atmosphere.
Correct.
And both of them, when they absorb carbon dioxide from the atmosphere, they create carbonates.
Okay.
Carbonates, I mean, I would love to tell you is that whenever you have a NaOH or sodium hydroxide bottle in your laboratory, you will find on its neck white precipitate keeps happening with the time.
Yes, sir. Yes, sir. Yes, sir.
That is nothing but carbonates.
Carbonates. Correct.
Okay, sodium carbonate precipitates.
Yes, sir.
So even if your R1 and R2 kept separate and lying for a long period of time, how to maintain the better stability? Keep it closed.
Okay. Yes, sir.
Don't keep it open for a longer period of time. And if possible, because this room temperature chemistry
Yeah.
lying open, you consider that as a chemistry not very expensive, so you can keep it open overnight. This
Yes.
will all develop the reagent performance change.
Correct. 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 Correct.
So keep it closed as far as possible. Keep it not at a high temperature. Keep it in the AC lab. If preferred, keep it in the refrigerator. There's no problem in that.
True. True.
You will reduce the amount of carbon dioxide being absorbed and small these tiny crystals formation and dissolving into the solution lying as a tiny dots.
Correct. Correct, sir.
In the reaction system, when you are performing the test, the dots will come into light path.
Correct.
You know what havoc it can create in absorbance and factor both.
Yes, sir. Yes, sir. Sir, now questions are increasing, but we'll keep the session open till 12:30 because we were supposed to do it by 11:30, but we have crossed all the timings and all the limits also. One question has come from Shravan Kumar. Sir, open vial stability of liquid reagent.
Sir, okay. I like to comment on that.
Yeah.
Open vial stability on the liquid reagent. This is very, very critical, not in terms of only semi-automated, even for fully automated analyzer also.
Okay.
Because in their carousel, they keep this reagent bottles open.
Yes.
And when the bottles are open, they tend to absorb all the dust in the room, gases from the room,
Yeah.
and uh, I think these two factors are the major one which are playing. I'll just give you an example. Uh,
Yeah.
we had sold certain reagent to one of the lab, which is fully automated analyzer.
Okay.
And uh, as on a friendly basis, he said, I have no major issue in the reagent, but what happens, sometimes the reagent go off.
Oh.
I said, okay, fine, we will visit your lab. We
Yeah.
happen to be in that area. Lab was on the ground floor on the road.
Huh.
Anybody would walk, number of vehicles traveling through it.
Correct.
And in his carousel of the analyzer, reagents were lying open.
Oh.
And on the top, the carousel temperature control mechanism was failing.
Yeah.
And he was saying, majority of the time, I do not get the problem. I said, majority of the time, sir, you open and consume the bottle.
Correct.
Sometimes you don't.
Consume it.
That's where your problems are.
Mm.
So either I can't ask you to, extend your, airlock system in the lab. But I would certainly say one simple thing is that buy a thin polythene sheet, cover
Yeah.
the reagent carousel on the top. Even if your lid of the analyzer is lost, no problem.
Yes.
Cover it with a transparent plastic so
Mm.
that at least dust does not fall and you know what example, I mean, what reagent tray is moving or not moving, which reagent is over, not over. Everything you will be able to control, but at least dust you prevent it.
Correct. Correct, sir. Correct, sir. Very good. I think Mr. Sarwan Kumar must have understood it. Now, the next question is from Mr. Basin. In CRP test procedure, R1 reagent volume is higher than R2. Will this cause variation in the CRP result?
Okay, sir. Mr. Basim, please try to understand what is CRP-R1 and what is CRP-R2 reagent is.
Yes, sir.
CRP-R1 reagent is nothing but a diluent,
Mhm.
and R2 reagent is where the antibodies are stuck on a latex particle.
Oh,
Okay.
correct, correct.
Now you have to dilute R1 with the serum in order to get the optimization of the C-reactive protein concentration for R2 to react.
Correct.
It has to be 3:1 or 4:1 ratio. You can't suddenly start using R2 as a higher one.
Yeah,
More R2 you use, the more is expensive reagent you are wasting in testing,
yeah,
where the results are not going to come anyway.
correct.
Because antibody access compared to the C-reactive protein which is coming from the serum will have a prozone effect. You
Correct.
will not get the results all right, and you are wasting the reagent by putting more R2.
Yes.
Comparatively, R2 is the one which is having antibody stuck on latex particle. So please
Correct.
maintain what is recommended in that.
Very good, sir. I think Basin must be satisfied now. The next question is from Shashikant Tiwari. Wow, Tiwari's question must be addressed immediately.
Okay.
Sir, open reagent life of SGPT and SGOT after 30 to 60 days, absorbance slowly downs of semi-automated analyzer. Is
Okay, let me read it once again. Open reagent life of OT and PT after 30-60 days. Slowly down of auto analyzer. Sir, OT and PT. Uh, if he's referring to OT and PT, that means he's referring to working solution.
yes,
If he's referring to working solution, please ensure that there is an NADH in the reagent.
yes,
Okay, if there is an NADH in the reagent and if it is lying open for a long period of time,
yes,
it is bound to degrade to NAD plus.
yes.
When it degrades to NAD plus, its blank falls down.
Correct, sir.
OT
Correct,
and PT both are decreasing UV kinetic reaction.
yes, sir.
If it starts at the lower than 1.0 or zero point 0.9 optical density to start with at 60-second delay time,
Yeah,
you are bound to get results which are less when there is a sample volume, sample reading high.
yeah,
Because operation optical density of an OT or PT reagent starts between 1.5, 1.6 OD and finish by zero point 0.5 OD. This
correct,
1 OD difference in the range is
correct.
where the operation of GPT reaction or GOT reaction happens.
Yes,
But with the OD dropping down, performance will drop down for the high sample volume.
yes,
Number two, when you keep it reagent open for a long period of time,
yeah,
there is an enzyme stability issue
correct.
because OT, you have MDH as an enzyme and partially LDH also to take care of interference of pyruvate. And in case of GPT, you have a LDH as an enzyme which does the second reaction.
Very
If
true.
these enzymes are lying open for a long period of time,
Yeah,
there is a tendency, if it is, the question is open reagent life. Okay,
yes,
open reagent life means it is not in the refrigerator, it is outside. Outside means what temperature? These enzymes will fall. hence the second reaction, hence the NADH degradation, hence the OD, hence the factor, hence the results.
Very true. I think Tiwari ji, answer मिल गया. If you are satisfied with the answer, right? Thank you. Oh, he has given thumbs up. Thank you very much, Tiwari ji.
Thank you, sir.
Suresh
Thank you.
Gowda.
Thanks, sir. Thank you,
Sir,
sir.
why always problems with bilirubin and alkaline phosphatase calibration? Past and results not correlating, fully automatic, and sometimes value or coming zero and QC always plus or minus 2 HD. How to
Okay.
rectify the issue?
Okay. Now, he has said very clearly two chemistries which are highly sensitive. Okay, let's take first one, bilirubin total.
Yeah.
Okay. Why bilirubin total and ALP calibration passed? Okay. Results not correlating fully with the automatic and semi-automated value. Okay. Uh, or coming zero and even QC always plus minus 2 SD. How to rectify this issue? Okay, sir, this is what we have covered in our presentation anyway. Getting the QC within plus minus 2 SD is getting the right absorbance
Correct.
of the control.
Very true.
We run reverse.
Yeah.
Okay, getting the QC results within plus minus 2 SD or at the zero at the mean value is getting the right OD.
Correct.
If we don't get the right OD, why we don't get the right OD in case of alkaline phosphatase and bilirubin both?
Correct, sir.
Now, alkaline phosphatase and an enzyme is highly unstable.
Yes.
If any of the control serum you pick up and start reading its instructions for use, I mean how the precautions to take, alkaline phosphatase readings will increase after some time. So
Yeah.
use the control serum within this much of period. Any control serum will mention that.
Very true.
Okay. So first thing is please ensure that you are calibrating fine, but your samples are used within the time, or if it's a calibrator used within the recommended time period.
Yes.
Okay, that's one. And case of bilirubin, bilirubin is highly light sensitive. Even if you have a serum sample collected from a patient, don't keep it in the open light. Keep it
Correct.
under dark
Correct.
because it is a photosensitive chemical.
Yes.
That is why when the bilirubin in a physiological jaundice on babies increase,
Yes.
they are put in a photo chamber
Yes, sir.
for 3 days, 4 days after the birth to
Correct.
reduce that bilirubin value.
Correct, sir.
The
Correct.
bilirubin is light sensitive, hence you have to
Yes.
take care of the light part. Alkaline phosphatase, you have to take care that you use within the recommended reconstitution life of the control.
Correct, sir.
Okay. Beyond that, if you use it, even in the control or I'm sorry, in the calibrator, beyond the time, neither bilirubin value is stable nor alkaline phosphatase value is stable. So
Very
both
true.
of them will have a different value and you will try to mention the value recommended or mentioned on the mean
Correct.
that will not match.
Very true, sir.
So time is the issue in that calibration sample.
Time is really the biggest issue today also, sir. We have reached to 12:30. I think we have two, three questions. We will revert back to you. Sir, we will send you the questions. You will send us the answer. We'll get back to the participants with the
Yes, yes,
satisfactory
yes.
answers. So I would like to say thank you very much to you and the entire team of Anamol for agreeing to do this for our industry people training part के लिए जो किया है, तो we are really thankful to you, sir. So in case from my side it is a क्या कहते हैं vote of thanks on behalf of entire all participants, sir.
सर थैंक यू वेरी मच द
Yes.
जिस पर्पस के लिए हमने ये वेब सेमिनार शुरू किया है द पर्पस इज एम्पावरिंग द यूजर्स
Yes, sir.
or
Yes.
the decision makers in the lab where there is suitability is established.
Yes, sir.
वो empower होंगे मेरा पर्पस सॉल्व हो गया.
बिल्कुल.
एंड लेट मी से वन फिलोसफी ऑफ माय लाइफ इज कि आप जब ऑडियंस में बैठते हैं तो
Yeah.
आपके पास में एक चॉइस होती है आइदर यू सिट एज अ जज कि स्पीकर अच्छा था स्पीकर बुरा था स्पीकर के पास नॉलेज था स्पीकर और एल्स यू सिट एज अ स्टूडेंट कि मेरे लिए इसमें क्या है.
बिल्कुल.
So any appreciation you give it to me or all that is not important. सेटिस्फेक्शन तो तब होगा जब आपके इम्प्लीमेंटेशन में आपकी कस्टमर कंप्लेंट्स या सूटेबिलिटी या अडेप्टेबिलिटी में परसेंटेज एंड ड्रास्टिक इंप्रूवमेंट आएगा।
क्या बात है सर,
दैट इज माय।
बिल्कुल सर। थैंक यू वेरी मच सर, बहुत बढ़िया कहा सर आपने। और रियली सबसे इम्पोर्टेंट चीज वही है, सुनना, जज करना ये सब अलग चीज है, उसको इम्प्लीमेंट करना है। एंड
यस सर, यस सर।
थैंक यू सर। मेरे पास भी 4-5 अलग अलग क्वेश्चन आए, वो भी मैं इनके क्वेश्चंस में ऐड करके भेज दूंगा आपको,
श्योर
क्योंकि
श्योर सर,
मोबाइल पे भी क्वेश्चन भेज रहे हैं सर।
most welcome, and I would love to receive questions. That's my lovely area.
यस सर, यस सर। थैंक यू सर, थैंक यू वेरी मच
Thank
सर।
thank you, sir.
ओके सर, बाय सर।
थैंक यू सर।
Thanks, sir. Thank you.
थैंक यू, थैंक यू।